Thank you, Dr. Gleave. And thank you for guiding me through this presentation. So I'll be presenting about radical prostatectomy in the setting of high-risk prostate cancer today, and more specifically how we could potentially optimize our outcomes with neoadjuvant treatment. So prostate cancer is the second most common cancer in men worldwide, with 1.1 million new cases per year and more than 300,000 deaths. However, it exists across the disease spectrum, with patients with low-risk disease having a rather indolent course where active surveillance is now the standard of care, while patients with high-risk disease have a more lethal disease where extent of treatment currently remains unclear. The first reliable risk stratification schema was proposed by D'Amico et al., and it's based on digital rectal examination T-staging, pre-treatment serum PSA, and Gleason grade group. Various nomograms have used those variables to predict recurrence and survival, the Caton preoperative nomogram being the most well-known one. It's based on more than 6,700 patients treated at different academic institutions. Around 15% of all prostate cancer diagnoses are classified as high-risk prostate cancer, and as per the NCCN, EAU, and AUA, that would be defined as a clinical T3 stage on rectal examination, or a PSA of more than 20, or a Gleason grade group of 4 or more on biopsy. However, this definition is flawed because of the inherent inaccuracy in determining T-staging. T-staging results in both understaging and overstaging, which are quite common. In fact, Kowlessur presented a paper in April 2008 where he found that around 24% of patients who were initially diagnosed with a clinical T3 were found to be T2 after radical prostatectomy. MRI has been investigated in an attempt to improve the accuracy of T-staging. The Roche presented this meta-analysis in 2016, where they assessed the accuracy of MRI for local staging. They looked at 75 studies with 9,796 patients. Sensitivity, however, was only 0.57, resulting in significant understaging. However, specificity was pretty high at 0.91. The more recent risk classification systems include a measure of the overall extent of tumor in the biopsy specimen. This is based on the demonstration that percentage co-involvement with Gleason 4 and 5 disease drive the biology of the tumor and relates to prostate cancer-specific mortality. Indeed, it does seem logical for us to think that a patient with Gleason 4+4 disease in only one core will not have the same outcome than a patient with Gleason 4+4 in 6 cores. Some scoring systems have been developed to attempt to better classify risk by accounting for disease extent within the gland. And the CAPRA score is one such score. It stands for Cancer of the Prostate Risk Assessment. It was developed by Kupperberg in 2005. And it predicts cancer recurrence based on pretreatment clinical data. And importantly, among the pre-treatment clinical data, it also includes percentage positive biopsy scores. It was developed based on more than 1,400 med from the UCSF capture database. Various molecular tests have also been developed in an attempt to improve risk stratification. These include the cell cycle progression score, Oncotype DX, and the presence or absence of genomic alterations. The CCP score examines the expression of 31 genes involved in cell cycle progression, and it generates a score between -3 to +3. This is a strong predictor of clinical outcomes in their studies following surgery. You can see that the higher the score, the higher the prostate cancer mortality. So Lalonde, in a study published in 2014, explored DNA-based indices and measures of intraprostatic hypoxia. They developed a set of prognostic measures identifying patients at risk of biochemical relapse 5 years after radical treatment. The initial cohort was of 126 patients from Toronto, and their findings were subsequently validated in 2 cohorts from MSK and Cambridge. They identified 4 subtypes with distinct genomic profiles. Biochemical recurrence-free survival differed among the subtypes. The one with the best biochemical recurrence-free survival was patients with a genomic profile of subtype 4. Those were known as quiet genomes with few genomic alteration, and there it was 89%. Patients with subtype 1, characterized by gain of chromosome 7, were characterized by late recurrences after 3 years, whereas patients with subtype 2 and 3, characterized by either gain or loss of chromosome 8, had a biochemical recurrence-free survival in the region of 55%. They also found genomic instability to be prognostic in this study, with every 1% increase in percentage of genome alteration resulted in 5 to 8% decrease in biochemical recurrence-free survival. Tumour hypoxia was validated as a prognostic factor in other solid tumors, and they investigated its role in prostate cancer. However, in this study, hypoxia RNA signatures were not shown to be univariately prognostic, but it was shown to increase accuracy of percentage genome alteration. Indeed, patients who had a high percentage genome alteration with high hypoxic RNA signatures were shown to have worse prognosis. It is indeed the interplay between specific genes, general genomic instability, and tumor microenvironment that is responsible for driving the tumor biology, and the investigators used a supervised machine learning technique to develop a 100 loci genomic signature that's predictive of biochemical recurrence. You can see the red line there. Those are the patients whose genomic signature was positive, having a worse outcome than patients in whom the genomic signature was negative. Very importantly, this signature was independent of clinical covariables. This brings us to our patient, Mr. ZM. He's a 65-year-old gentleman. He had a prostate biopsy showing Gleason 4+5 disease in 8 out of 10 calls, PSA of 19.2, clinical T2B, and no mets on conventional imaging. So options traditionally available to him would be a radical prostatectomy plus lymph node dissection alone, or as part as a multimodal form of treatment. External beam radiation plus minus brachytherapy boost with long-term ADT for 2 to 3 years would have been another option. And historically, it has been preferred prior to 2010. This is data from the Capture database showing that most patients with higher CAPRA score, significant for high-risk disease, were being offered either, quite surprisingly actually, primary androgen deprivation therapy alone, or external beam radiation with radical prostatectomy being offered in less than 15% of patients. Indeed, most randomized data in this setting pertains to radiation therapy. This is a National Cancer Institute of Canada PL3 study where they randomized 1,205 patients with high-risk locally advanced prostate cancer to either a combination of RT and ADT or to ADT only. Hazard ratio was in favor of the combination at 0.77. At 7 years, 90% of patients who receive ADT and RT were alive, compared to 79% of patients who receive ADT only. So subsequently confirmed by the Scandinavian Prostate Cancer Group 7 study, which recently published its 15-year outcomes. They had 875 patients, 90% of whom had high-risk disease. And again, they were randomized to either the combination of ABRT and ADT or ADT only, hazard ratio of 0.42 in favor of the combination. At 15 years, prostate cancer-specific mortality for ADT only was 34%, against 17% for RT and ADT. And we do know that concurrent administration of androgen deprivation therapy improves the survival in radiation as opposed to sequential administration of ADT. This has been shown in various ARTOG and EORTC trials, where combination treatment not only resulted in a reduction in local recurrence, but also improved survival in high-risk disease. So why does ADT work so well? Why does radiation work better with ADT? ADT sensitizes prostate cancer cells to radiation. It not only reduces the tumor volume, but it also promotes apoptosis, it reduces hypoxia in tumor cells, and we know that hypoxia is a factor in radioresistance, and AR regulates DNA repair genes, and ADT leads to impairment of DNA repair mechanisms following radiation therapy. What those studies emphasize, though, is that the treatment of the primary tumor is paramount, not only for local control, but also to prevent further seeding of distant metastatic sites. What about surgery in all of this? It does provide immediate and excellent local control. It provides us with a definitive way to stage the patient and hence guide further treatment if needed, and definitely avoid overtreatment. And another advantage is that it will allow us to promptly detect any signs of biochemical recurrence. Surgery does work well in high-risk disease. This was a series published by Loeb et al. In September 2011. They had 175 patients classified as high-risk by Damico's criteria, and the 10-year cancer-specific survival was 92%, with a biochemical recurrence-free survival at 68%. Also, comparing across trials, this compares very favorably to the radiation randomized trial. Our experience has been extremely favorable as well. Comparis published a study in the CUAJ in 2011. We had 299 men with NCCN classified high-risk prostate cancer, 67% of whom had PSA 8 to 10 disease. Median follow-up was 4.7 years, and our cancer-specific survival was 99%, with an overall biochemical recurrence of 30%. We also looked at factors predictive of PSA recurrence and univariate analysis, and we found that percentage core positive and number of risk factors were predictive. You can see here that patients with one risk factor, the black line, did much better than patients with 2 or 3 risk factors. So how does surgery compare to radiation plus ADT? Well, to date we don't have any large volume or contemporary randomized control trial. However, we do have numerous propensity adjusted analyses, which is basically a statistical matching technique that estimates the effect of intervention by accounting for covariates that predict the propensity of receiving that treatment. However, it only accounts for observable covariates. The study was published by Abdullah in 2012. It extracted 68,665 patients from the SIA database. He used a propensity score matching technique to minimize the potential bias related to treatment assignment, and then used competing risk analysis to test the effect of treatment type on cancer-specific mortality. Radical prostatectomy was favored in all of his subgroups, including those patients with short-term comorbidity index of 0 and high-risk disease. The study was published by Berg in European Urology last month. He had 13,985 patients from the National Cancer Database, all of them who were less than 35, relatively young, short-term comorbidity index of 0, and high-risk disease. And again, he compared radical prostatectomy to a combination of EBRT, brachy, and ADT. Of note, 15% of the patients in the radical prostatectomy arm received adjuvant RT. And there was a higher risk for mortality in the radiation therapy arm with a hazard ratio of 1.22. This table is a summary of the mortality results from studies using propensity analysis. There are 14 studies listed here comparing radiation to radical prostatectomy, 6 of them with more than 10,000 patients and 2 of them with more than 60,000 patients, and all of them favored radical prostatectomy in terms of either prostate cancer-specific mortality or overall survival. In summary, there are no large randomized controlled trials comparing the two. However, the most stringent retrospective analysis favor radical prostatectomy, and there is certainly no evidence that radical prostatectomy is inferior in this setting. And we have seen that there has been a reversal in the historical trends of the way patients were treated for high-risk disease. Radical prostatectomy is now the main mode of treatment for those patients, and reassuringly there has been quite a significant decline in the number of patients receiving primary androgen deprivation therapy. However, the therapeutic challenges in high-risk prostate cancer do not only pertain to local control, but also to the systemic control of micrometastatic disease. And that's where neoadjuvant treatment can potentially optimize outcome for high-risk prostate cancer. It provides us with earlier systemic therapy for dealing with micrometastatic disease. It achieves cytoreduction, hence reducing the likelihood of a positive margin. But it also allows us to assess treatment effects on the specimen and also assess in vivo surrogate biomarkers of treatment response. And it's potentially better stratifying our patients and accelerating drug development. So agents used in the neoadjuvant setting have historically been used in the metastatic setting first, prior to being transposed to earlier disease states. And in prostate cancer, those are agents that are targeted towards the androgen receptor pathway or chemohormonal agents. Labrie and colleagues from Quebec were among the first to show an improvement in pathological outcomes. They did a randomized controlled trial with 161 patients being randomized to either prostatectomy alone or a combination of GnRH agonist and flutamide prior to prostatectomy. And they found that in terms of pathological outcomes, there was a higher incidence of organ-confined disease in patients who received combination therapy and a higher incidence of negative margins. And we do know that one of the central tenets of neoadjuvant therapy is that local tumor response correlates with long-term outcomes. We see that in breast and bladder cancer, where pathological complete response is a significant predictor of improved clinical outcomes. Is that true for prostate cancer? Shelley et al. Published this meta-analysis of the historical neoadjuvant RCTs in 2009 and found that unfortunately there was no overall survival difference. However, the caveat here is that most of the patients in those trials were low-risk patients, and the number of events were very, very low. The next question asked was whether 3 months was too short of a duration for ADT, and Dr. Gleave published this study in 2001. He did a randomized controlled trial with 502 patients. Patients were randomized to either 3 months of ADT or 8 months of ADT. And in terms of pathological outcomes, the 8 months group was favored. The pathological complete response rate was higher, so was the number of patients having organ-confined disease, and there was a lower number of patients having positive lymph nodes. However, there was no difference in biochemical survival rates, biochemical recurrence rates at 5 years. So why is that discordance? Well, again, the majority of patients in those trials did not have high-risk disease as contemporarily defined. There were too few events to show a difference in terms of overall survival. There was indeed site-to-site variations in PSA recurrence, and those variations were independent of clinical variables. So one of the confounding factors here was likely to be the surgical technique. We also do know that GnRH agonist alone causes an inadequate suppression of tissue androgen levels. And it is also likely that even in the localized disease state, ADT-resistant cells are already present. So we now know that in the castrate-resistant setting, cells maintain a degree of hormone sensitivity after initial castration, and further androgen blockade in CRPC is an effective treatment option. So can more potent androgen blockade make a difference in the neoadjuvant setting? Abiraterone and enzalutamide are the two main agents that can achieve more potent blockade. We all know that abiraterone is an irreversible CYP17 inhibitor, and enzalutamide is a second-generation androgen receptor inhibitor. The initial survival benefit was seen in the castrate-resistant setting, and now we are seeing benefit in the castrate-sensitive setting, with their use in earlier disease provide benefit. This study was published by Mary Terplin's group in November 2014. She did a randomized controlled trial with 58 patients, 74% of whom had high-risk disease. They were randomized to either an LHRH agonist or an LHRH agonist plus abiraterone. All those patients had a protocol biopsy at 12 weeks, followed by everyone having LHRH agonist plus abiraterone for another 12 weeks, and then radical prostatectomy. The primary outcome here was intraprostatic androgen levels at 12 weeks, which was seen to be reduced with the addition of abiraterone. And secondary outcomes included pathological assessment. So we saw that with longer duration of the combination of LHRH agonist and abiraterone, the number of patients achieving complete response were higher, and so was the number of patients achieving what they arbitrarily define as minimal residual disease at prostatectomy. However, the response in this study was almost dichotomous, with patients either achieving a minimal residual disease status that they define as a tumor volume of less than 0.25 centimeter cube, or having extracapsular extension, which was seen in more than 50% of patients, and the rate of nodal disease was relatively high as well in this study. Moving on to enzalutamide, Montgomery et al. Published this study in May 2018. It was a randomized controlled trial across 4 sites, including Vancouver. 48 patients with intermediate to high-risk disease were randomized to either enzalutamide or a combination of enzalutamide, dutasteride, and an LHRH agonist. We can see in terms of pathological response, at least from a complete pathological response rate, there was not much difference between the two. Only one patient achieved complete pathological response in the combination arm. However, quite a significant number of patients achieved what they define as a minimal residual disease status, and as a combination arm, almost 74% of patients. Paradoxically, however, the number of patients with positive lymph node in the combination arm was higher than in the enzalutamide only arm. From a translational standpoint, they found that there was a correlation between lower intraprostatic androgen levels and lower residual cancer burden, which may suggest that AL signaling may contribute to the survival of tumor cells. So this table is a summary of the pathologic outcomes from clinical trials of contemporary neoadjuvant deprivation therapy. The columns on the left represent various combinations of Zoladex, dutasteride, bicalutamide, and ketoconazole. And the right ones are the more contemporary 12 weeks and 24 weeks abiraterone, as well as the enzalutamide studies. Again, those are phase 2 trials with relatively small numbers, but in general, the trials where contemporary androgen receptor pathway inhibitors were used were associated with generally higher pathological responses. So what can we infer from those studies? Well, combination therapy leads to more intense suppression of tissue androgens and AR activity, but some androgen metabolites and AR activity still persist in treated prostate tissue. There's a larger proportion of patients achieving minimal residual disease status after contemporary maximal androgen blockade. However, the definition of what is a minimal residual status is not standardized and not established in the literature. And also, we do not know whether this is a useful surrogate in prostate cancer. In an attempt to explore more complete androgen blockade, McKay and al. Did a randomized control trial published last month in the Journal of Clinical Oncology. They had 75 patients randomized to either a combination of abiraterone and enzalutamide and leprolide, or enzalutamide and leprolide only. 78% of patients in this RCT had Gleason 8 disease or more. However, in terms of pathological outcomes, there were more patients in the combination arm achieving at least minimal residual disease status. However, the pathological complete response rate was still low at around 10% and not significantly different between the arms. They also found that patients with ERG positive or PTEN loss tumors had more extensive residual tumors, and none of those patients achieved a minimal residual disease status, either because they had larger baseline tumors or possibly because they have less AR dependency, hence making them less likely to respond to targeting of the androgen receptor pathway.
Is that the Harvard group?
Yeah, Boston. So in all these contemporary phase 2 neoadjuvant ARPI trials, a small proportion of patients seem to have a significant pathological response. So our outcomes improved in patients who do respond well to neoadjuvant hormonal treatment. The study, again, McKay and al. Published a study in September 2018. They did a pool analysis of patients treated on the 3 contemporary neoadjuvant trials with a primary endpoint of time to biochemical recurrence. The numbers were quite small, but they had 11 patients who achieved a tumor diameter of less than 0.57, and the biochemical recurrence-free rate in those patients was 100%. That compared to a biochemical recurrence-free at 3 years for patients with tumors larger than that, which was 67%. So although we need longer follow-up and numbers are limited in this study, this initial data in the contemporary ARPI setting is encouraging and may suggest that pathological complete response rate may be predictive of recurrence. However, this should be interpreted cautiously, since pathological complete response was not associated with improved biochemical recurrence-free survival in the 3 versus 8 month study published back in 2001, and which was a much larger randomized control trial.
So just comment on that. They're including the NHT enzalutamide trial, which of course is a trial including our study. Post end of study, which most of those studies end because of pathological endpoints. We had one P0 recur. So it's not 100% because we actually had one patient out of that group that did recur, but it's not captured because the trials end follow-up too short because their endpoints were principally pathological.
Okay. Interesting. Sorry? No. So they didn't have MRI. Its tumor size was not assessed before treatment when you have residual disease.
How do you do that?
Sorry?
How do you
Oh,
determine size beyond?
well, if we were, we would do MRI, and that would have been underestimated anyway.
They're all high risk disease. They don't characterize by
Tumor size.
volume.
Yeah. Well, they stratify it according to the NCCN or D'Amico criteria. So if you met the criteria, then you were characterized as high risk.
That is changed. We'll come to it in the future trials. That's recognized as a problem.
Yeah, so yeah, that's what I said in the first few slides. So in summary, contemporary MAB protocols do seem to impact pathological outcomes, although pathological complete response rates are still relatively low at around 10%. It's possible that our sample size are too small in those trials, hence not powered enough to detect differences in pathological outcomes. It's possible also that we need more prolonged regimens. We saw that in Mary-Tepian study where giving 24 weeks of abiraterone resulted in better pathological outcomes. We also saw that in the 3 versus 8 randomized trial, longer treatment results in better pathological outcomes. But what's more likely is that we have inherent resistance mechanism that are already present in localized disease. Hence, a biomarker to identify those tumors that may benefit would be of particular value to us. Nevertheless, the safety and relative response rate in phase 2 trials has led to a multi-center international phase 3 trial with UBC as one of the main sites. The recruitment for this trial will start in a couple of months, and the aim is to accrue 1,500 patients. Patients will be randomized to an investigational group of either ADT plus apalutamide or a control group which will receive ADT plus placebo, which will be followed by radical prostatectomy, followed by adjuvant treatment again with ADT plus APA or ADT plus placebo. Our primary endpoints are pathological complete response rate, but more importantly, metastasis-free survival, with secondary endpoints of PSA-free survival, progression-free survival, and adverse events. This brings us to the second regimen used in the neoadjuvant setting, and that's chemohormonal therapy. So docetaxel and cabazitaxel are the two agents used in the prostate cancer setting. They cause microtubule inhibition, and we also know that normal microtubule function is required for AR nuclear localization. Taxane-based therapy not only causes disruption of the cell cycle, but it also downregulates the androgen pathway signaling. Hence, chemohormonal therapy has potential to eradicate ADT-resistant cells that arise early in treatment with ADT only. Over 10 years ago, the TAX327 and SOG 9916 trial demonstrated that treatment with docetaxel resulted in a 20 to 30% relative improvement in survival and a median improvement of 2 to 3 months in terms of median overall survival when compared to metoxantrone. We have seen that this benefit is even better in earlier disease, in the metastatic castrate-sensitive setting. This is the charted trial, which is well known to us, is a ratio of 0.61 in favor of combination. This was subsequently confirmed with the Stampede trial, has a ratio of 0.76 for the combination. So this is a GTOC 12 trial, an interesting study where chemohormonal treatment was used neoadjuvantly. Relatively large 413 patients randomized controlled trial, 42% with lesion 8 and 59% with PSA of more than 20. Randomized to either a combination of ADT plus docetaxel and extramustin or ADT only prior to radical treatment. The relapse-free survival favored the combination of docetaxel and ADT, 62% against 50% at 8 years. Hazard ratio was 0.71. However, what limits the practical applicability of this study is its unusual design. Indeed, all patients there had a pelvic lymph node dissection and then were randomized, followed by systemic treatment, following which they had interval radical treatment. If their lymph nodes were positive, they were either offered a choice of radical prostatectomy or radiation, and if the lymph nodes were negative, it was either radical prostatectomy or radiation, and if their lymph nodes were positive, it was either observation or radiation. This brings us to our Canadian Uro-Oncology Group single-arm multi-center phase 2 trial, where neoadjuvant ADT plus docetaxel was investigated in 72 patients with high-risk disease. Median follow-up was 42.7 months. PSA recurrence was 30%. Also comparing across trials, it seems favorable as PSA recurrence rate are in the 50% range in historical high-risk cohorts. Even more encouraging was the PSA recurrence-free survival of 89% for the 2 patients with a pathological complete response and the 16 patients with 5% or less tumor by volume in the prostatectomy specimen. All this leads to the much anticipated Cancer and Leukemia Group B or Alliance 9203 trial. UBC was one of the sites for this trial. We had 788 patients with high-risk prostate cancer. Those patients had to have a biochemical progression-free survival rate of less than 60% by the Caton nomogram, PSA of less than 100 and clinical T-stage less than T3A. They were randomized to either prostatectomy or a combination of docetaxel and ADT prior to prostatectomy. Primary endpoint was biochemical recurrence-free survival at 3 years, and the results were recently presented at the EUA a few days ago. Median follow-up was 5.1 years. There was no significant difference in terms of 3-year biochemical recurrence-free survival. During the entire follow-up, when they increased the follow-up period to the entire follow-up period, though, hazard ratio was 0.66 in favor of neoadjuvant docetaxel, 95% confidence interval of 0.47 to 0.94. However, what tempers enthusiasm a bit for this result is the fact that 42% of patients were non-evaluable for biochemical progression-free survival. They also analyzed overall survival and found a benefit in favor of chemohormonal treatment. Hazard ratio of 0.67. However, you'll note there the 95% confidence interval exceeded 1. This is likely because the total number of events was relatively low in this trial. We will have a clearer picture, probably confirming a survival benefit with longer follow-up as we get more events. We know that pathological complete response rate following contemporary combination regimens remain low at around 10% in prostate cancer. It differs rather significantly from pathological responses that we see in bladder and breast cancer, which are more in the region of 30% and are associated with improved outcomes. So how can we further improve outcomes in this setting? This is where precision medicine comes in, where we target molecularly targeted agents. We match those molecularly targeted agents to distinct genomic and molecular aberrations within an individual patient's cancer. We do know that numerous genomic aberrations drive progression and resistance in the metastatic setting, although this mostly accounts for around 20% of patients. Hence, we could have novel combination tested based on actionable genomic alterations in an attempt to improve our pathological complete response rates. This brings us to the GUN study, the Genomic Umbrella Neoadjuvant study. In the study, which is in the final stages of approval, patients with high-risk prostate cancer would have genomic profiling and be started on a GnRH agonist plus apalutamide for 8 weeks, following which they would be assigned to one of 3 groups. Group 1, with no targetable aberrations, would have intense targeting of the androgen receptor axis. Group 2, who have loss of tumor suppressor genes such as P10 and P53, would be targeted with chemotherapy. Group 3, with DNA damage response alterations. Here we have quite a specific agent to use in the form of PARP inhibitors. And finally, Group 4, with hypermutations and microsatellite instability, accounting for the minority of patients, would have PD-1 inhibitors targeted. So in conclusion, radical prostatectomy is a valuable option in patients with high-risk clinically localized prostate cancer. However, we do need to optimize our outcomes by incorporating neoadjuvant and adjuvant therapies into the treatment paradigm. The Proteus trial will provide us with insight on whether oncological benefit can be derived from contemporary neoadjuvant androgen receptor pathway inhibitor, and the recent results from CALGB do confirm a possible benefit from neoadjuvant chemo-hormonal treatment. Future studies will explore combination therapies, and I believe that genomic guidance will be key to appropriately select patients for those individual therapies. Thank you.